Good evening, everyone, and a very warm welcome to tonight's Ask the Expert. My name is Paula Hanford, and I am the CEO of PSC Support. We're absolutely delighted that so many of you have joined us tonight for this Ask the Expert session. It's a special session with Dr. Roger Chapman. As you know, PSC can be a complex condition, and for many people, the terminology around, the different forms of terminology around PSC can be confusing. What exactly is small duct PSC, and how does it compare to classic PSC, if you like? And what do we mean when we talk about PSC and autoimmune hepatitis overlap? And what about IgG4 related PSC? Is that part of PSC or something else entirely? And these are important questions because they can affect how PSC is diagnosed, how it's monitored and managed, and how people living with PSC understand your own condition. So we are very fortunate tonight to help us navigate this topic. We have Dr. Roger Chapman, and Dr. Chapman is internationally recognised as one of the leading experts in hepatology in this country and overseas, with decades of experience of PSC and other liver diseases. He's now retired from clinical practice, but he has contributed hugely to our understanding of PSC through his clinical work, teaching and research. And he's been a long-standing supporter of PSC Support. In fact, Roger helped to set up the charity 30 years ago in 1995. Roger then served as one of our trustees, and he's recently retired from that. I say recently, Roger, it's probably about 3 years ago now. And he's been the chair of our scientific review committee. So he's been hugely influential in the PSC world. This evening, Dr. Chapman will talk us through different PSC variants, what they are, how they differ, and what they mean for patients and clinicians. And after his presentation, we'll be taking questions and answers. So please put them in, any questions that you have, throughout the presentation. Please put them in the questions and answer box. So without further ado, I'd like to introduce Dr. Roger Chapman. Thanks, Roger.
Thank you very much indeed for that very generous and kind introduction. It's really a real pleasure for me to talk to PSC Support again because we were talking beforehand, I helped sort of form a bit with Ivor Zweigler back in 1995. We formed PSC Support, and it's been such a success. Nothing to do with me, but to do with all the excellent support of the administration and also all the patients who raise so much money, which I now give out. We manage to give out a lot of money every year through our research committee, which has been very exciting and produced a lot of wonderful research, which is going to take forward both our understanding of the disease and also hopefully treatment of the disease as well. So it's been a real pleasure. So if I may, if I hopefully can get up my slides, we'll have a look. If it's okay, Mark, here we go. Share. There we are. So thought I'd start by telling you all about my first case I ever saw of primary sclerosing cholangitis. I was a very lowly senior house officer working in Southampton in the gastroenterology unit. I hadn't quite decided then what I wanted to do. I wanted to be a cardiologist, actually, but I was told that there was no future in that, which turned to be not a very good prophecy, actually. But anyway, cardiology has expanded, but as indeed did gastroenterology. So I saw this young man in his 30s, and he was jaundiced, and this was a really quite a sick young man, and we didn't have MRCP or any other imaging. So I was struggling to learn ERCP, which is an endoscopic technique where you take pictures of the bile ducts, which I'm sure you're aware of. And we did that, and we diagnosed this young man as having PSC. He had ulcerative colitis, I then went to the library. It wasn't like having Google. It took a long time to go to the library in those days. Ploughed through all the books, and I saw that the first case of PSC had been described by a chap called Delbay back in almost 100 years ago now. But following that, this is in 1976, I said there are still less than 150 cases in the whole world literature. And basically, the disease was thought to be like this man in this picture here. This is a very old slide of mine, but it shows how we used to think about PSC. This is a young man. He's not smoking because PSC are non-smokers, as we know, but that's a thermometer, old-fashioned thermometer. His beads are square. He's got cholangitis. He's grabbing his abdomen, and he's got terrible-looking bile ducts and rip-roaring colitis. And almost all of that is probably a very atypical and doesn't represent, as you all know, the actual patients who have symptoms of PSC. But what that did was that stimulated me to become a hepatologist, believe it or not. And I then went up to the Royal Free Liver Unit, which at the time there were two preeminent liver units, there's Royal Free and King's. And it was ruled really by a very scary but a wonderful woman called Sheila Sherlock. And I went up for an interview to see whether she would take me to do a research degree of MD, PhD. I went in to see her, knocked on the door, and there she was looking, marking exam papers, and she didn't even look up as I sat down. And she said, what would you like to do to study when you come to us? And I said, I'd like to do PSC. And she said, there's nothing in that, she said, nothing at all in that. You're going to do iron metabolism. So I duly did iron metabolism for my thesis. But we managed to collect. I managed to collect quite a few cases of PSC. We published it in 1980, and it sort of took off from there, really. So that's how I got into PSC, and it's been a great. I hate the word journey, but it's been a great journey, I suppose, over the last almost 50 years looking after PSC. So without further ado, I'll just move on, if I may. So you will know all this, but just to briefly set the scene to remind you what the biliary system is. There's the liver, the largest organ in the body under your ribs on the right. And from that, two big bile ducts come down. The left hepatic duct and the right hepatic duct carry the bile from the liver down into the gallbladder where it's stored. And then when you eat, then the bile passes out of the gallbladder into helping digestion, as well as getting rid of various other things as well. The toxins. And they're divided into the intrahepatic bile ducts, which you see are right and left hepatic duct, and then the extrahepatic portion is the bile duct, which is outside the liver. This, as you see, is actually quite important. So you can measure it by MRCP, which is the non-invasive form, which we have now. And then in certain cases, you may proceed to do ERCP, which is endoscopy. Both here showing the wonderful tree-like. These are both normal pictures of normal biliary system with tree-like smooth tapering from the common hepatic duct to the intrahepatic bile ducts. So just to remind you and just to define it, it's a chronic, which means it's long-standing and progressive. Can be progressive, not always, as I'll explain as we go on. The disease, often over many, many years, the biliary tree, and it's characterized by this scarring process and the bile ducts. So I'll show you pictures as we go. So the bile ducts become thickened and narrowed, and this in certain cases can cause a stricturing, so-called narrowing of the biliary system, shown over here. This is here on a normal bile duct here, and here a sclerosing cholangitis patient with also ulcerative colitis and multiple stricturing of the biliary system, and that's the stricturing which can cause so-called main duct strictures with blockage of the extrahepatic bile duct. Sorry. So again, you'll know that PSC has a number of associated disorders, which again are relevant when you're working out the prognosis and the variants of the disease. Of course, the main association is inflammatory bowel disease, both ulcerative colitis and also Crohn's disease, but that's also a different story in itself, which we'll come to. You have cancer of the bile duct or the colon. It's increased in PSC. Again, not always, but as I'll come to. And also you have an overlap with other autoimmune diseases as well. Now, this points to the possibility that different genetic constitutions play a role in different individuals with PSC, because some will have PSC, not all, as I'll show you in a minute, will have IBD, not all will have other autoimmune diseases. But it suggests that there are shared genes between PSC and other autoimmune diseases, particularly, but also some cancer genes as well. So normally it's known as particularly had to have male predominance. And here you see an enlightened male here. Male predominance being the feature, was thought to be the future of PSC, but as we know, can also affect females. And just to move the picture slightly here, sorry. I just moving Mark, i.e. Paula, aka Paula, and myself down in the picture. So PSC in 1976, there was just thought when I saw that young man back in that time, there was only really one thought of disease, a very severe disease which caused jaundice. And then we realized there were different associations. First of all, there was IBD, 70-80% of IBD, and also someone have ulcerative colitis, someone have Crohn's, and that becomes important, as I'll show you. Some, about 15%, do not have IBD, although some of them will go on to develop it over time. And some will have, as Paula mentioned, the really quite recent disease of IgG4-related biliary disease, in about 5%. Now we now realize that these different distinct types have completely different clinical courses and prognosis. I'll try and attempt to elucidate those for you tonight. Going back to IBD, first of all, because it's so important. This is quite an old slide of mine from Oxford about 10 years ago. And we looked at the distribution of the patients. 21%, as I showed before, didn't have IBD. And then Crohn's, 13% had Crohn's. Majority of patients have ulcerative colitis. Well, but when we looked at it, thought we thought it'd be a good thing actually to look at Crohn's disease and see what it was like, because we had the impression that Crohn's disease patients did better. And that indeed turned out to be the case. It's really quite marked differences. Unlike PSC UC, people with PSC Crohn's disease were as likely to be as female as male. So 50% versus a big difference. More commonly had small duct PSC, which has major prognostic implications, and much less commonly progressed to cancer of the liver and probably of the colon, and less chance of going on to liver transplantation. So this was, really quite major differences, which has been, I'm glad to say, borne out by other findings since. So again, you're looking about PSC, what the variations in PSC, there are really a number of combinations with different prognoses. You can have extrahepatic PSC with large duct, with only extrahepatic ducts involved, intrahepatic only involved, both involved, which is the commonest sort. And in this group of patients, there's no need for liver biopsy to confirm the diagnosis. In contrast, small duct disease, as I'll show you, will have normal bile ducts. And in that situation, it's mandatory still, even in this day and age, to do a liver biopsy to make the diagnosis, because the diagnosis is made in that situation. Now, also to say that it is associated with inflammatory bowel disease, and indeed, IBD can develop some years after diagnosis of PSC, but not infrequently develops the first time after liver transplantation, interestingly, for PSC. So it can develop, and that's why, hopefully, you're all receiving 5 yearly colonoscopies, even if you haven't got diagnosed IBD. If you're not, you probably should be. And each variant, as I say, has a different clinical course. So if you look at just the simple first, very commonest things first, if you look at intrahepatic versus extrahepatic PSC, so intrahepatic, again, the liver comes in. These ducts here are in the liver, above and then below the colon. But when they join, that's extrahepatic, and they have really quite different symptomatologies. If it's intrahepatic with a sparing of the extrahepatic bile ducts, you will get progressive liver disease, usually, not always, but usually, which can cause biliary cirrhosis, liver failure, and require liver transplantation. In the lower duct, as I already mentioned, you have a so-called dominant stricture, which completely blocks the flow of bile. In that situation, you get jaundice, bacterial cholangitis, which is a biliary infection, which is actually really quite uncommon, but certainly can happen and can be a difficult complication. And also the complication, which I know you're all aware of bile duct cancer. And this occurs mainly in extrahepatic disease. And I mentioned the colon cancer risk. Again, I think, if you have PSC, there's a 30% risk of developing dysplasia, early cancer at 20 years, which is why, hopefully, you have early colonoscopies straight away, and this can be picked up early. And if you're not getting early colonoscopies, you should be. Hopefully, the doctor will do that for you, wherever you may be. If you have PSC without UC, the risk of colon cancer is hardly raised at all. This is interesting. And that Crohn's disease, again, much less of a risk. And you may ask, why am I getting a yearly colonoscopy for Crohn's disease? Well, I think the jury's out really as to whether that needs, but certainly the risk is much lower in Crohn's disease. Moving on to variants and overlaps, I've already talked about small duct PSC, and we'll talk more about it in a minute because it's very important. As Paula intimated, there's an overlap syndrome with autoimmune hepatitis, and we're going to deal with IgG4 related cholangitis. So this is what small duct PSC is. It's a unknown cholestatic liver disease, chronic liver disease, a normal cholangiogram. But we have this amazingly, this is the bile duct is here, and normally it'd be a nice smooth outline around that bile duct. But what happens is you get scar tissue around that bile duct, so-called concentric or onion skin. It's like an onion, and that's a characteristic diagnostic lesion in the liver of sclerosing cholangitis. When you have that, and if you have the presence of IBD, that's quite clear. It is a form of PSC. There are other diseases which I won't go through, which can give you sclerosis of the bile ducts, but it can be very commonly seen in patients with ulcerative colitis and particularly Crohn's disease. So it has a similar median age, small duct to large duct disease, about 38. It can occur in children, though, and can occur in elderly, more elderly patients. Again, there is a male predominance. And again, there's a 4-to-1 incidence of UC to CD in the 81% of the patients. But the difference is that the patients often have early disease. The majority of patients will have early disease. So we looked at the follow-up of these patients. This was, I think, quite an important paper we did. We Scandinavians and ourselves in Oslo and Sweden. We looked at all our patients, and we looked at patients with small duct disease. And we noted for the first time that the patients went on over a period of about 13 years. About 1/4 of them went on to develop large duct PSC, but 75% of them didn't, and they stayed well. None of the patients had cholangiocarcinoma in that group, and the risk of going to liver transplantation was much reduced, and that was only in the patients who developed large duct PSC. And if you look at the survival, we were actually astounded by these results, actually, as to how good they were really. So this is a transplant-free survival over a 15-year period. And in the solid bar at the top is small duct disease, and in the bottom is the hatched area is patients who had large duct disease. And you'll see that in terms of requiring a transplant, it was much rarer in patients over 15 years in patients who had small duct disease. So a really marked contrast in prognosis. So the conclusions from all that is, just to recap for you, you have a normal cholangiogram, you have an abnormal liver biopsy with this fibrosis again shown around it. It's common in Crohn's disease. It's not associated with cholangiocarcinoma, probably less chance of getting dysplasia and colon cancer. But interestingly, I won't show you the slides, but ursodeoxycholic acid clearly does not help. So there's no indication for urso in patients who have small duct disease, and it has better prognosis. So just to summarize for you, again, I don't want to repeat it again, but that there are various sort of clinical phenotypes. The clinical phenotype is the type of disease that you get with a certain condition. There's IBD associated, non-IBD associated, large duct and small duct, and there are various factors which I'll mention in a minute, which with large duct disease, which can influence prognosis. So this came from about 2010. A group of us got together in Oslo. We formed an international PSC consortium, which has been a very amazing, really, group. Which what it did actually got all the experts from the whole world together. And we meet on a regular basis every 2 years. And I've actually stopped going about 2 years ago now, sadly. But it was a great forum for A, meeting other people in the condition, and B, for doing very important joint collaborative studies, which have been producing great results. So then one of the people in the group got together all the patients from the consortium, which was about over 8,000, about 7,900 patients back in 2017, and looked at all these sort of phenotypes which I've been talking about. So we'll call them low risk and high risk. So females basically do have a lower risk of going on to progressive liver disease, require transplantation, and males, small gut mentioned, do better. Intrahepatic disease, they do better. No IBD do better than IBD, and Crohn's do better than UC, as I showed you. If you keep low enzyme levels just below the upper limit of normal of a liver blood test called alkaline phosphatase, you have a normal or low level, the patients do very well. And a normal IgG4, I'll come back to IgG4, but some few patients that come back who do have PSC, don't have IgG4 disease, have a slight elevation in their IgG4, which actually is associated with a higher risk of progression. And then there's a blood test marker called the ELF test, which is a marker of different measures different things in the blood, of fibrosis scores and everything else. So a low ELF score, you do well, and a high ELF score, you don't do so well. So what that means is, as a PSC doctor, you can sit down in the clinic and go through and decide whether that patient is low risk or high risk, and certainly that's a very useful risk classification. Then on to the PSC overlap syndrome. As I alluded to already, that the there are a number of four basically autoimmune liver diseases. There's primary biliary cholangitis, which had, I think, a major World Health Day last week, I think, and autoimmune hepatitis, PSC, and IgG4 disease. Overlaps occur, so an overlap occurs between autoimmune hepatitis and primary biliary cholangitis. However, PSC, you'll notice, does never overlaps with PBC. They can be quite similar in terms of their presentation, the abnormal liver function tests, itching, fatigue, but they are quite separate diseases, and there's no overlap. Autoimmune hepatitis, there is an overlap, as I'll show you, and there's where it is actually controversial where there's a true overlap with PSC and IgG4 disease. Again, I'll cover that in a minute. So if you look at the PSC, group of PSC patients, group of patients who have autoimmune hepatitis with typical antibodies and typical liver function tests, abnormality with high enzymes, high transaminases, and also have typical changes on liver biopsy, about 6 to 8% of patients will have overlap between autoimmune hepatitis and PSC. It often can manifest that the autoimmune hepatitis can predominate early on, and as the disease progresses, the PSC becomes more obvious. That's certainly true in children, I think, who children can present with PSC with an autoimmune type disease. It used to be called autoimmune sclerosing cholangitis, a term which I hate, but there certainly is an overlap. And the treatment this is how we defined it. Again, we got together, a group of us, a long time ago now, 15 years ago, and we did a case review and decided that PSC overlap syndrome is an ill-defined immune-mediated disorder characterized by the liver biopsy features of autoimmune hepatitis and the bile duct changes on cholangography of PSC. So I think it's important because the various guidelines, these are our early guidelines, but they've just been guidelines in 2022 from the European guidelines, and it states it's got a very good document actually, and within it they restated what we said: the corticosteroids and other immunosuppressants are not indicated for the treatment of PSC in adults unless there's overlap syndrome. But if you do have an overlap, as we mentioned, there is an indication for steroids, and so such patients will have corticosteroids, usually for 6 months to a year, and will then be maintained with azithromycin as immunosuppressant. Cholestasis, well, that could be nor-urso or urso these days. I'll come back to that at the end. What about IgG4 disease? Well, it's a multi-system immune-mediated fibroinflammatory condition, and it's a condition which we've had a major interest in Oxford. My colleague Emma Culver, who you may have heard of, is taking over the autoimmune clinic, and she has become, we could say, the queen of IgG4, and she produced many publications as well on this disease. It's a disease of a immunoglobulin producing lymphocytes, small white cells, which can involve various organs. Almost every organ in the body can be involved in it, and it causes, again, that sort of scarring inflammation which I showed you, but it can occur in almost every organ system of the body, brain, a number of situations. A thyroid, eye, everywhere. But the two most common organs which are involved in IgG4 disease are the pancreas, causing a condition called autoimmune pancreatitis, and also in red, a biliary system causing IgG4-related cholangitis, known as IRC for short. I thought I won't show too much of the slides histology, but basically this is remarkable. When you look after these patients, it's remarkable. They will present again. This is identical actually with a patient with PSC. This is an IgG4 related patient, a man. Again, it's male predominant, just like PSC. Very common, particularly in Asia, in Japan and China, who first reported this condition. which when it first came out, I said we didn't in the West, we didn't believe it, but we were quite wrong. It certainly exists and exists in the UK as well. And this is a condition which can affect the bile duct, causing main duct strictures and also multiple strictures of the biliary tube. So before treatment, and then 3 months later, this is the same patient. I promise you, you'll see the bile duct is completely normal after steroid therapy. This is actually what there's again a story involved here. I didn't believe that the condition existed. We diagnosed it first about 2001. And this was one of the first patients I had. He was an Asian man who had been diagnosed as having cholangiocarcinoma. He came to us and we diagnosed that he had IgG4 disease on a blood test and biopsy. And gave him some steroids, and he completely recovered. And he then very kindly asked me to his daughter's wedding about 5 years later. So he's done very well and didn't have cholangiocarcinoma. So again, the question arises has been arising is it one disease or are they related? And the reason for this was that unlike PBC, where very rarely you have IgG4, you do, as I mentioned already, have low levels in this is Oxford patient. This is not Oxford patient; it's a patient from the States, but it's the same in Oxford. 9% of the patients with true PSC will have a slightly raised IgG4. Why is this important? Well, it does appear this got therapeutic implications again, in that this is patients who, without having a liver transplantation, with a normal IgG4, these are patients with PSC, they eventually will often require transplantation, not always. But this is patients who have a slight elevations of IgG4 for reasons which aren't clear. They have a worse prognosis. I know that's been investigated thoroughly at the present time, but in Oxford. So, to sum up, is there a true overlap syndrome between PSC and IgG4 cholangitis? They're both autoimmune diseases. They have some shared genes, but not very many. They do have similar bile duct changes, but they respond very well to steroids, immunosuppression therapy. They have different disease associations, and IgG4 really has no strong association with IBD, only a slight one. There's only elevated, and the levels in PSC patients a few PSC patients are very low. So I think on balance, I think it's accepted the PSC, PSC and IgG4 are very separate conditions, and they're not true overlap in that stage. So just thought I'd finish about the possibility of treatment. I think just aim. I think I can, as I'm now retiring, I can talk about the future as people often do, and I think that. I think Norurso, you may have been involved in trials of Norurso, and the results were produced, I think, when the EASL meetings very, very recently. And we were involved in the first trial, and I was actually on the trial committee, I'm pleased to say. And what they gave Norurso for almost 3 years, not quite 3 years, and they had liver biopsies before and afterwards. And they had a control group of PSC patients who had placebo. And they found that about 15% of the patients with Norurso actually improved either their liver function tests, and the liver biopsies did not worsen over a 3-year period, whereas much higher percentage of patients who didn't have treatment developed higher liver function tests and also had worsening in their scarring in their liver. So it does appear to be really a useful drug. I think it will find a place in treatment if it's cheap enough. Depends how expensive it is, but I don't. Unfortunately, it's not silver bullet. It's not going to cure 100% of patients. It's going to help a small percentage of patients with PSC. I think, putting it in context. Just to finish, I think a very topical subject, and I think I don't know if Paul is on the line, but there's a study I'll mention in a second in England, UK, I should say, of fecal microbiotic transplantation, so-called FMT, in PSC. And it's become really very trendy treatment in all sorts of liver disease, all sorts of conditions, is to measure the type of bacteria in the biome, the bacteria in the colon, and to see whether that may be driving the diseases, various diseases, number of diseases, actually extraordinary, liver diseases, a lot of liver diseases. And so there's interest in changing the biome in the colon. If it's going to put you haven't had your supper, it may put you for your supper. This, I warn you. But this was an initial trial, came from America, And a very small so-called pilot study, just 10 patients, 9 had ulcerative, 1 had Crohn's disease. They, via colonoscopy, infused normal stool culture into the colon, had no adverse effects. And in PSC, there's a reduced number of bacteria in the colon, an increased amount of a bacterium called Veillonella. And they managed to change that, and just with one infusion via colonoscopy of fecal transplantation. And interestingly, they also, by doing that, produced a 30 to 50% decrease in alkaline phosphatase. Now, there's a big study going on in, I know, in Europe, and also there's a study, Palak Trivedi in Birmingham is doing a study called the Fargo study. I think Paula will correct me, but maybe funded by PSC. But it is, I think it is, it's a great thing to be studying.
Yes, partly funded by us.
Partly funded. It's a great study, and so it's great to be associated with it. Before I was before I was the chairman of the scientific committee, before my time, but it was a great thing to fund. I think it offers the future. They're doing a different form of just for if some of you listening, maybe watching, maybe on this trial, you may not want to talk about it, but what it actually I think in practice is one fecal infusion by colonoscopy, and then weekly for 6 weeks getting enemas of normal bacteria for the normal patient's colon. I'm not aware of any results yet, but they should be coming out hopefully in the near future. And I think it's really quite hopeful that fecal microbiota may be important. I haven't got a slide, but also, as you'll know, there's some evidence that vancomycin, particularly in children, may be of use. And again, that may be by a direct effect of vancomycin on the immune system, which it certainly has, but also may be due to affecting the colonic biome as well, which is very important. So that's quite a sort of skip through if I may, probably a bit long of PSC. There's a very famous professor who very sadly died 2 months ago called Michael Manns. I've known him for 40 odd years. And in that, when we started the PSC International Consortium in 2010, he described PSC as the last black box in hepatology, by which he meant a lot of other liver diseases, hepatitis C, hepatitis B, autoimmune hepatitis, all of those have been largely effectively treatments that were available. But here in 2025, I think the black box is creeping open, but still, I think we have a lot to hopefully find and discover in terms of biomarkers for cancer, in terms of studying the course of the disease, and also finding some better treatments. So thank you very much indeed. I'd like to thank you for your attention, and hopefully can take some questions. Thank you very much indeed.
Oh, thank you very much, Roger. We had somebody put in the question and answer section that they saw you and heard you speak just as they were diagnosed some time ago at a really early information day. And she said you were a great source of information and comfort to her then. So
well, it's very kind, Paula. I really enjoy those days because it's nice to actually to meet people in that sort of scenario, and it's been a very lucky career. Really, it's been great.
Very good. So thank you very much. I've got a question that we received before tonight. So
right,
was sent by email, and you talked about small duct PSC and the different prognosis between small duct if it just stays as small duct PSC to large duct PSC. But the question is, if you move from small duct to large duct, does that mean that the disease is progressing?
The answer is sadly it does, and yeah. So once it progresses, it's only over a lifetime. It's only about a 25% chance of that happening, as I said. But yes, once you've got large duct disease, you are on a more progressive liver condition, which may eventually come to transplantation. Yeah. That's unfortunate, but I think the thing to stress is large majority of them don't. Yeah.
Yeah, that was a good point you made earlier. Same person, I don't know what the person's name is, but the same person has asked this question. Also, what relevance does the diameter of the common bile duct have in the progression of the disease?
Well, that's a good. Again, I didn't touch on that. There's a new development called MRCP Plus, which I was sort of involved in through a country, through a firm in Oxford, whereby with MRCP you can actually measure quite accurately progression. And it's been looked at to see whether that can actually predict bile duct cancer at an earlier stage. Hasn't really shown that, but you can measure the bile ducts, and basically the smaller they get it, the tighter they're getting, the worse the prognosis would be. So yes, and that would be an indication then for sometimes for putting in a stent or for stretching up the bile duct by at ERCP. But the technology again is advancing. I think I've got great hopes for MRCP Plus actually in terms of being predictive. It's a question. There's a very controversial area is whether people with a PSC, a large duct PSC, should have a yearly MRCP. And I think I've always felt that the evidence wasn't that I'm not there to follow that, and I think that's still the case. I just, funnily enough, reviewed a paper from Australia last week. I don't review too many papers these days, but it interested me. So, and again, it showed that MRCP has really never been shown to be worth it in terms of picking up. It's surprising, but it's true. But you'll find that many units in Europe and America will do yearly MRCP. But I think the future in terms of picking up cancer at an earlier stage, which certainly is biomarkers, and we know again from the work of doctors, again supported by PSC support in Barcelona and so in Madrid, doing some great work with some very exciting biomarkers. Biomarkers are things in the blood which predict that cancers may be occurring or may likely to occur. And I think that has a great future in PSC. I really do. And that looks like it's going to be exciting. Is exciting already, actually. Yeah.
Very exciting already, exactly. And I think that's music to the ears of people listening
Yes.
today.
Yes. Yeah. Exactly. Yeah.
Got a question about URSO.
Yes.
Well, it's a two-part question actually. Can you tell me how autoimmune hepatitis influences PSC and the
Yes.
role
Yeah.
of URSO? So the person is saying that I have AIH for 50 years and this
Yes.
was diagnosed with PSC. About 18 months ago, I stopped taking URSO. Is there a connection?
That's what actually then develops. Actually, so a connection with what? I'm not quite sure
I
what
think
the
the connection, is there a connection with us stopping, oh, he or she, I don't know who it is, stopping URSO and developing PS, being diagnosed with
I
PSC?
don't know why would she be on URSO if she had autoimmune hepatitis. That's the question. Because he wouldn't normally be on URSO for autoimmune hetitis per se. I think if you have PSC, to slightly not quite answer the question, if you have PSC and you stop URSO, by and large it worsens the PSC. It's been a very controversial area, which I've been fairly heavily involved in over the years, as to whether URSO should be given or not. I think there are a proportion, about 20% of people who do respond to URSO. And I see that in the latest European guidelines that they do recommend giving URSO as a thing. I think probably that would change recently to be NOR-URSO rather than URSO if it's funded. But it is true that if you have the good news is if you have autoimmune hepatitis variant with PSC, your prognosis is better by and large in the long term. Yeah, so that's which is good. Yeah.
Why do you think that is, Roger? Has there been any research on that?
That's a very good question. Maybe a slightly different, a more autoimmune component. Maybe I don't know. I don't know. I wish could answer that. I don't know. But it would appear to be a fact. The patients who do have autoimmune hepatitis presentation will do better. And then, but by and large, particularly in the children, over the years, the autoimmune hepatitis sort of dies off, if you like, becomes quiescent, and then the PSC takes over.
Okay, thank you for that. So we've had somebody posting that they were diagnosed with UC and PSC at the same time. And a different person has asked, is it possible that both UC and PSC develop at the same time? I've always had
Well,
somebody.
I'll answer that differently, so I can present. I don't. I think UC PSC is a different condition to UC. There's quite good evidence for that now. So it's a condition in its own right. So that basically, what happens is you pick up them at the same time. Often, if there's no symptoms, often it's different clinical course, as we all know. The colitis is generally much milder in the UCPSE, and it's routine and mandatory. And when you're diagnosed on a cholangiogram as having PSC, if you haven't got symptoms of colitis, you still have a colonoscopy, because you will often find ulcerative colitis mainly often on the right side of the colon. But as a rule, the colitis forms a difference, or it's milder. Despite the fact it has a higher cancer risk, it's actually, in terms of inflammation, in terms of causing attacks, it's generally much milder. And it's also, as I said, quite an interesting phenomenon that once you put a new liver in, the colitis often gets worse, which is a phenomenon in itself unexplained. But I think UC and PSC are complete. UC PSC is a different disease genetically, completely. There's some cross overlap of genes, but not very many. It's a separate condition.
Yeah, it's so interesting. We've had we've got 15 questions, so I'm trying to get through as many as possibly can. Somebody's asking how they don't know if they've got large duct or small duct PSC. They're living in a different country in Mexico. They have been diagnosed with PSC, but not a specific type. What should they ask their hepatologist?
They certainly should. Yes, no, they should. They should ask that. That's right, because it really makes a huge difference. Yeah, as regards treatment, I suppose as well. Yeah, I can. Yeah, I think I can think of a. Yeah, no, I think. Certainly should. There's quite clear evidence that Ursu doesn't help that. That doesn't help that really. So it may influence treatment. And also, yeah, but I think as a patient, I would like to know whether I had large duct or small duct disease, and the patient should be told that. Absolutely.
Okay, so ask them
Yeah,
what type of
yeah.
PSC you have. Another question about small duct. How do you monitor progression if small duct, if MRCP does not show anything and LFT are pretty normal?
Well, it won't. It won't. By progression, we mean developing changes on the cholangiogram. So that you would monitor that by monitoring liver function tests on a yearly basis and monitoring symptoms. So if they develop symptoms of itching or rarely cholangitis, for example, that would suggest that the large ducts are involved, and then you would do a cholangiogram, MRCP. And then if MRC, that cholangiogram then will tell you whether the large duct disease has developed and it's progressed. It's not routine to do a MRCP routinely in small disease unless there are a change in symptoms or blood tests.
Okay, another question with about small duct, large duct. Probably quite an easy question for you to answer. Are intrahep and extrahepatic ducts and large and small ducts the same thing with a different name?
No. So no. So the intrahepatic and large ducts are, when we're talking about small duct PSC, we're talking about microscopic under the microscope. So that's how it's diagnosed, small duct. The other ducts, the large ducts on the cholangiogram will be, even the small ducts you see on the cholangiogram will be normal with no narrowing.
Okay, thank you very much for that. IgG4, interesting.
Right.
Disease. Can it be diagnosed by liver biopsy during ERCP? So the person is saying, I'm having an ERCP due to sudden onset of pruritus and elevated liver biochemistry and suspicion of dominant stricture. My IgG4 is raised and the IgG4 IgG1 ratio is slightly over 0.24. I'm wondering if biopsies of strictures taken during the ERCP would also reveal IgG4 disease.
That sounds like the patient so does have IgG4 disease. That has to be said. I don't think you can't really do a liver biopsy of the RCP. What you can do is you can do a brushing of the bile duct. So there's a main duct stricture, because there is a slightly increased risk of cholangiocarcinoma 2 and IgG4 disease. You would certainly you don't biopsy directly at the time of ERCP, but you would only do an ERCP again, I think, if there's a main duct stricture, so the patient is jaundiced or has cholangitis. And if that's the case, you certainly do a brushing, a cytology, so called it, at the RCP, and then you probably would relieve the obstruction by doing a dilatation and by putting a stent in temporarily. Yeah. Yeah.
So so I was just going to answer something and it just jumped. So not answer, ask. So this person was diagnosed with PBC a year ago.
Right.
This year
Really?
he had I'm not sure if it's a he or she, had an MRCP which showed dilated bile ducts at the border of liver segments 7 and 8, measuring up to 3 millimeters. The diagnosis is PSC. Now, is this diagnosis reliable?
Well, again, it's hard to comment, but in PBC, there are diagnostic antibodies, antimitochondrial antibodies, which are present in the vast majority of people who have PBC. They're not present in PSC. So having said that quite firmly, I've never seen a crossover in the whole of my career between PBC and PBSC. If she has got proven stricturing in the bile ducts, but just one stricture would be slightly worrying me. I think you'd have to have multiple strictures to say the patient's got PSC. And if she's got antimitochondrial antibodies, otherwise PBC, it may be other atypical form of PBC, I would suggest. But I'm saying all of this without seeing any of the data, so I shouldn't be doing that really. Yeah, but still, yeah.
And I didn't quite get from that whether it was diagnosed with PBC, but then actually they re-diagnosed.
Maybe a misdiagnosis of PBC. Yeah. There is a type of PBC which is called AMA negative PBC. That's measured normally on a liver biopsy changes, which are characteristics of PBC, which are a bit different to PSC. Well, very different to PSC. Yeah.
Okay, I presume it's a parent of a 15-year-old asking a question here. PSC, UC, and AIH in a 15-year-old, asymptomatic. Could it be that over the years he will remain without symptoms, or does the disease necessarily have to progress?
I think it, and sadly, I think it is likely that the PSC component of that will progress. Yeah, and that so that it means clearly should be monitored at least on a yearly basis with liver function tests, and if any symptoms develop at all, or there's significant worsening in the liver function tests, then they should have repeat cholangiograms and a yearly, obviously a yearly ultrasound anyway, which every patient should have as well for looking at the gallbladder. So I think my feeling would be that it's likely to progress in the young child with the PSC over time, and you have to follow them closely is the answer.
Yeah. You mentioned vancomycin in your introduction, in your presentation. The question here is, what are your thoughts about vancomycin as related to microbiome impacting in PSC?
Well, I did actually. I think I did an article on. I think still on the website on vancomycin, which so you can basically. I think the thinking is not sure whether it alters the biome or whether it actually alters. It has an effect on the immune response as well, which is lymphocytes in the gut. So I can't entirely answer that. It's clearly you think it would affect the biome, and it's a very good question. I'm not sure any data is showing whether the biome has been assessed before and after vancomycin. It's a very good question actually, but I can't answer that thoroughly. But I'm sure it would have an effect on the biome, and whether that may be why it appears to be quite useful in some patients with PSC. I can't answer.
Okay, thank you for that. So another parent. We have a couple of parents at least on today. My son is 8 and he has PSC autoimmune hepatitis. Does URSO help with this? They said that he's refusing it at the moment, but does
he is receiving it?
Refusing it at the moment.
Sorry, receiving it. He's getting it.
He's refusing it. He's saying
he's refusing it. Well, I think strictly there's no strong evidence that URSO helps PSC. It's very controversial. It certainly helps liver function tests, I think I say it's still in the European guidelines. You should try it. So I think if he has a child with autism, the main way of treating them would be corticosteroids. So I think it's quite reasonable he refuses it. for the time being, and just to keep an eye and see what happens. And as these liver function tests become more cholestatic, higher alkaline phosphatase, then they could certainly try a new treatment, which may be NORISO or whatever, or fecal transplantation. But I think at the moment, as a young child, it is quite sensible just to treat him with the corticosteroids.
Very good. That's. I'm sure that's very comforting to know. I'm sorry if you can hear noise from my upstairs. It sounds like I've got a herd of elephants, but
It's okay.
it's boys just walking around. I don't know what they're doing.
Yeah,
Anyway,
that's all right.
apologies. Another question about small duct PSC. So this person has small duct, no IBD. I was given a acoustic bowel test prior to deciding if a colonoscopy was necessary, and then was not given a colonoscopy. Was this bad practice? Now that seems to me that
That's different. I mean, acoustics is looking for blood in the blood and to see whether any colon cancer risk. I think it's just slightly unproven as to whether patients with small duct PSC require regular colonoscopy. I think under the guidelines they should have it on a regular basis. So I'm surprised that she was refused colonoscopy. And also, if she has a positive poo test, that was certainly, I would say, in itself is an indication for colonoscopy. So I think she needs a colonoscopy.
okay, so please do push for a colonoscopy. Let's have a look. Is it possible to have PSC overlapped with a genetic liver disease, not PBC or IAH? I've recently had a sudden onset of pruritus and elevated LFTs. My hepatologist says I may have a second predisposing factor based on genetics beyond PSC, and I will be having cholestatic genetic studies to investigate.
Gosh, that's a complicated question. I can't, without knowing what they're suggesting it might be. But if you've got PSC, then that's going to give you cholestasis. So in itself, but by cholestasis, I mean blockage of bile flow. When I say cholestasis. So I think I would need chapter and verse on that. Perhaps if she could write in and let me know what the disease is, I could answer it directly for her. But there's no obvious link between PSC and other, I'm aware of, other cholestatic diseases. But of course, they can occur incidentally, I suppose. So coincidentally. So yeah, I don't know the answer.
Okay, I've got a question here about some medication. Now, I'm going to struggle with this, but I'm going to give it a go. Do you know about mycophenolate,
Yes.
mofetil, or reductase?
Mycophenolate. It's like azathioprine. It's a long-standing immunosuppressant. I think there have been some reports that azathioprine may be, and especially in long term, maybe of some benefit, but no real clinical trials. Mycophenolate would often be, it may be well be given for the ulcerative colitis, which has got ulcerative colitis,
It is
in terms of or Crohn's disease. Yeah.
AIH. They've been asked if they want to take it for AIH.
Yeah, that would be reasonable. Yeah, in fact, there's increasing evidence that in AIH it's probably as good, if not better, than azathioprine. So that'd be very reasonable. Yes.
What about rituximab?
Rituximab is used. It's not been trialed in PSC. It's a treatment used in IgG4 disease. Again, we've done a fair bit of work. Like I say, Emma Culver's done a lot of work in that in Oxford, looking at rituximab. It's a long-standing. It affects B cells, B lymphocytes, and IgG4 is a B lymphocyte disease. And in patients who don't respond to steroids, a minority of patients, they have infusions of rituximab, which in the long-term basis. It's a profound immunosuppression, so you have to be a bit careful about existing TB or other diseases have to be excluded first. But rituximab is I'm not aware of it being trialed in PSC. I don't think it's not likely to be trialed in PSC. I don't think. So because PSC is not an IgG4 dependent disease.
Yeah, they were talking about it in relation to IAH. And
Yeah.
we only have a couple of
Oh,
minutes.
IIH. Sorry. Okay. Yeah, no, it may well be. I'm sure it will be trialed in IIH for patients. Yes, that's a different question, I suppose. Yes, yes. That may be. There's no evidence I'm aware of, but it would be logical to try it if the patient's really resistant. But there are plenty of treatments for IIH which would not include rituximab.
Thank you very much. So we have a couple of minutes left, Roger. So I'm going to finish on this question, and it's a big question.
Right.
What do you see for treatment and prognosis with PSC in the next 5 to 10 years?
I sort of hinted at that. I think
Yeah.
prognosis. I think we'll certainly get better tumor markers around, so we'll be able to diagnose cholangiocarcinoma at an earlier stage. I think that's going to happen. I think scanning will for cholangiocarcinoma will get better as well with MRCP plus and other conditions. Treatment wise, gosh, so I think URSO is a minor step. NorURSO is a step forward, but it's not a silver bullet really. I think fecal transplantation will prove to be very interesting, and if I put my money in 5 years' time, I would suspect that we'll be using fecal transplantation. It's been used for a condition called Clostridium difficile colitis, which is infective, but it's been very, very effective in that it's been trialed with some effective results in ulcerative colitis without PSC. So I think that maybe fecal transplantation would be where I would say. There are some other things in trial which are of some interest, but none look particularly exciting at the moment to me. So I don't know really. Yeah.
Okay. Well, Dr. Chapman, thank you so much. We are now at
Pleasure.
8 o'clock, so we are going to close the Ask the Expert for this evening. But thank you so much for very generously giving us your time and your.
No, it's been a pleasure. I couldn't. I mean, PSC sport's been part of my life really. So it's been nice to be able to finish out on PSC support. Good, very good.
Very much appreciate it. And thanks to everyone who's joined us this evening. Thank you so much, Dr. Chapman. Thank you.
Pleasure. Okay. Thank you very much indeed. Bye bye, everybody. Thank you very much. And good luck, everybody. Thank you.